there to come in and join us, but I don't want us to go over time. So I'm going to go ahead and introduce our next presenter, Dr. Rahul Tendulkar. So Dr. Tendulkar is an associate professor and the associate residency program director here at the Cleveland Clinic in the Department of Radiation Oncology. He specializes in the treatment of breast and genitourinary cancers. Welcome.
All right. Thank you, Dr. Valenti, for that introduction, and thanks everyone for being here today. It's been a nice reunion of sorts for many of us who don't always get to see each other in person as much anymore. So I've been asked to talk about nuances of radiation therapy in the treatment of lobular breast cancers. This is, I think, a really nice topic for the meeting today because it's something that doesn't get a lot of attention. And so hopefully we can go over some of the data as it pertains to radiation therapy in the management of these patients. So as we've heard already today, lobular breast cancers represent a fairly unique entity. About 10-15% of all breast cancers are comprised by the lobular subtype. And as we've heard, these tend to be more often multifocal, multicentric, and commonly bilateral in terms of their pattern of spread. And in addition, they're less mammographically visible or palpable. And so MRI can be quite useful in terms of staging and understanding the extent of disease as it pertains to local therapy management decisions. And as we'll hear from Dr. Cruz and others this afternoon, these also tend to have a different response to systemic therapies. They are often less chemosensitive and more hormonally sensitive as well. And so how does this pertain to radiation therapy? Well, historically, radiation therapy decisions have been made irrespective of histologic subtype. And so I think it's really important to consider whether lobular carcinomas require any kind of special consideration for radiation therapy. So we'll talk about a few different scenarios in which we use radiation therapy. So historically, whole breast radiation therapy has been used for going on about 5 decades now. This started with standard fractionation and has evolved more towards hypofractionation, and I'll explain what that means in a little bit. In addition, in the last couple of decades, partial breast irradiation has become quite more commonly utilized as well. And then lastly, we'll also talk about post-mastectomy radiation and the use of elective nodal radiation for patients with high-risk features. So first, a bit about whole breast radiation. So this was used in really the original trials that compared mastectomy to breast conservation therapy that were done starting in the 1960s, 1970s, and published in the 1980s. And really, I think the probably seminal work out of this was Bernie Fisher's paper, the NSABP B06 trial, that was a randomized trial between mastectomy, lumpectomy alone, and lumpectomy plus radiation. And as we can see here on the bottom left panel, up to 40% of women after breast-conserving surgery alone suffered from an in-breast tumor recurrence, suggesting that after the gross tumor is removed, a substantial proportion of women had residual microscopic disease left in the breast. And we could see from the graph down below that this results in that radiation therapy results in a significantly less risk of local recurrence. And then the EBCT-CG meta-analysis in Lancet in 2005 collected this plus a number of other randomized trials and pooled the data together, and again showed a substantial reduction in the risk of local recurrence, which we knew from the individual trials. But what was important about this meta-analysis was that for the first time we saw that radiation therapy to the whole breast resulted in a reduction in mortality due to this. And so we learned from this what we call the 4-to-1 ratio. So for every 4 local recurrences prevented at 5 years from radiation therapy, resulted in 1 life spared at the 15-year mark afterwards. And so this really was a big paradigm change over the last couple of decades. So standard fractionation refers to the use of radiation therapy, which is the dose that we use is in gray, so 1.8 to 2 gray per fraction, which is given to the whole breast over 5 weeks, typically followed by a boost given to the tumor bed over another 1 to 2 weeks. And again, this was the standard of care from roughly the 1980s until the 2010s, certainly until at least the last decade it's been used. But there are some drawbacks, certainly, to this, as you saw some of the cosmetic issues that Dr. Bernard pointed out. In addition, the long duration of treatment made it a barrier to treatment completion. So a substantial number of women would undergo a lumpectomy and not actually receive radiation therapy. And so that posed a major challenge, particularly those patients who may not live close to a radiation facility. This was really a tough thing to go through. As it pertains to lobular carcinomas, the available data suggests that outcomes for lobular carcinomas are actually very comparable to those treated for ductal carcinomas. A series from Yale showed essentially the same local recurrence and distant metastases rates, but lobular carcinomas had roughly double the incidence of contralateral breast cancers in follow-up. And a series from Dana-Farber also showed similar rates of local recurrence and distant metastases, but lobular cancers more frequently needed re-excisions for positive margins, again, as Dr. Mukhtar had nicely shown us earlier. And so with regard to standard fractionation whole breast radiation therapy, the 7 series published here, this is a paper by Chirag Shah, my colleague in radiation oncology, from 2011, across the board showed absolutely no difference in breast tumor recurrence rates between those treated for those treated for lobular carcinomas versus ductal carcinomas. And so, this, again, has not been a factor that we've really considered in terms of decision making. So how has radiation therapy evolved over the last few years? Increasingly, there's been a trend towards what we call moderate hypofractionation. So hypofractionation in radiation simply means fewer fractions. So in order to achieve the same biologically effective dose as standard fractionation, we basically just have to give a little bit higher dose per day and do that in a shorter period of time. And this is really attractive in the treatment of certain types of cancers that we treat in radiation oncology, breast cancer being one of the more common ones. And that's because slow-growing tumors may respond better to high dose per fraction compared to low doses per fraction given over a longer period of time. And so if we can complete a course of whole breast radiation in 3 weeks, as opposed to 5 to 7 weeks, that might result in more compliance and ability to receive adjuvant therapy that can, again, result in a reduction in mortality, as we saw. In the case of lobular carcinomas, these tend to be more commonly low and intermediate grade in comparison. And so these types of tumors may be particularly useful to treat with moderate hypofractionation. Really, the first seminal trial of hypofractionation whole breast radiation was from the Ontario Oncology Group, published by Tim Whelan in 2010. They compared 2 sets of treatments, so 42.5 gray and 16 fractions over 3 weeks, compared to the standard fractionation 50 gray and 25 fractions over 5 weeks. There was no boost that was used to the tumor bed in either arm. And again, notably, the main finding was that there was absolutely no difference in breast tumor recurrence or cosmetic outcomes between these 2 approaches. And this was corroborated by a number of other studies, which I'll show on the next slide. But one interesting finding from this original publication was that for patients with low and moderate grade tumors, there was, again, their hazard ratio was on the side favoring hypofractionation. But for the high-grade tumors, the more fast-growing tumors, there was a suggestion that a standard fractionation regimen may be better. This finding was not actually corroborated by the other trials that followed. So the START-A study compared 3 different fractionation schedules. One was whole breast radiation, 50 gray, 25 fractions, and then 2 other fractionation schedules giving treatment every other day over 13 fractions. So that was still 5 weeks. And what we found was that in the 39 gray arm over 13 fractions, that resulted in less induration, telangiectasias, and edema. And then the START-B study, which was a follow-up, also done in the UK, compared simply 40 gray and 15 fractions versus standard fractionation. Again, no difference in local recurrence rates, and the hypofractionation arm had less breast shrinkage, telangiectasias, and edema. So again, suggesting that moderate hypofractionation may actually have some cosmetic advantages over standard fractionation. And then the fourth and final study was the Danish one, which was published more recently in 2020, again showing that using the same schedule of 40 gray and 15 fractions, showing essentially identical local recurrence rates. And this one also showed no difference in cosmesis or toxicities. Unfortunately, there have been no subset analyses of lobular carcinomas in particular in these trials. And so the best conclusion that we can make is that we should really treat them no differently than other subtypes. ASTRO, which is our American Society for Radiation Oncology, published our executive summary guidelines suggesting that, or stating that moderate hypervaccination whole breast radiation is an appropriate standard of care for most patients with early stage breast cancer, including those with high grade, young age, having chemotherapy and larger breast size, and may be appropriate for those with breast augmentation and certain collagen vascular disease. So again, there's no conclusions made about lobular carcinomas separate from others, so we essentially treat them the same. The next evolution in terms of fractionation schedules is what we call ultra-short fractionation. So instead of going from 5 weeks down to 3 weeks, can we do all of the radiation therapy in just 5 treatments, perhaps as short as 1 week? So again, the UK group are the ones really pushing the envelope in this space. The first trial that they published was the UK FAST study, and they looked at 3 arms. The UK group, they really love doing these like 3-arm trials where one arm is standard and then they look at 2 different doses that are not very far apart from one another, but they compared 50 gray and 25 fractions versus 30 gray and 5 versus 28.5 gray and 5. These were given once a week. And they found no difference in terms of normal tissue effects with the 28.5 gray, but it was worse with the 30 gray arm. And the in-breast tumor occurrence rates were the same. And then the fast-forward study, instead of once weekly treatments, they basically did it on 5 consecutive days. They lowered the doses a little bit, so 27 gray in one arm, 26 gray in another arm. I would never have expected to see a difference in outcomes with a 1 gray difference in total dose, but that's what they found, was that apparently 26 gray was essentially the same as 40 gray and 15, but there were worse toxicity outcomes with the 27 gray arm. So if we were going to do 5 consecutive days of whole breast radiation, 26 gray is the dose that this study found. And again, unfortunately, there were no subset analyses of lobular carcinomas in these trials. They did report that about 10% of patients in the fast-forward study were lobular carcinomas, which is, again, consistent with what we would expect. But again, the recurrence rates were so low, in the ballpark of 2% or less across all 3 arms, again, suggesting that we really shouldn't treat them any differently if we're going to be doing whole breast radiation. All right, moving on to partial breast irradiation. So this has been another evolution in recent years. So why do we consider doing partial breast irradiation? Well, it's because most local recurrences occur in the index quadrant. Whole breast radiation came about, again, 50 years ago, and I like to think of whole breast radiation as basically idiot-proof. Kind of just give radiation to the whole breast and try not to miss. It should be very simple. In recent years, we have much better imaging, so we have an ability to detect where the original tumor was, and we can target our radiation therapy towards the cavity much better than we were able to do decades ago. So there are now 3 major forms of partial breast radiation. So there's interstitial brachytherapy, which kind of looks like a medieval torture situation, but we use many catheters that go through the breast, and then we use temporary radiation that dwells within the breast. It delivers the radiation, and then everything is removed. And then there's intracavitary brachytherapy, which usually uses a single catheter with often a balloon or a strut-based system to deliver radiation therapy. Again, brachytherapy basically means just giving radiation internally on a temporary basis. And then there's external beam radiation therapy, which can be used with what we call either 3D conformal radiation or IMRT, both of which use multiple beams aimed at the target. And so I apologize for the busy slide, but these are all of the major partial breast radiation trials that have been compared to whole breast irradiation over the years. A couple from the European group, we're using interstitial brachytherapy, the first one that we saw, that showed that partial breast radiation improved cosmesis and toxicity rates. And then a publication from the Florence group using IMRT, 30 gray in 5 fractions to the partial breast, resulting in similar rates of local recurrence, but less toxicity and improved cosmesis in the partial breast arm. This fractionation schedule has been our preferred technique here at the Cleveland Clinic, kind of across the board. And I think a lot of it has to do with how much dose we're giving in a certain period of time. And so giving 30 gray either every other day or even once daily seems to have pretty good outcomes. And then more recently, the import low study, which was not what we call accelerated. It was partial breast, but not accelerated. They gave 40 gray and 15 fractions whole breast, but also 40 gray and 15 fractions partial breast. So the same time course, so it was not an accelerated course. And again, partial breast radiation did have less changes in terms of breast appearance and less hardness. And then the last two were the RAPID trial and then NSABP B39 studies. These are the 2 largest multi-institutional clinical trials. And what was notable about these is they both used predominantly 3D conformal, entirely in the RAPID trial. And then NSABP B39 was over 70% external beam with 3D conformal techniques. But their fractionation was actually a very kind of a high dose. It was a BID schedule. Patients got treated twice a day for 5 consecutive days. So this is quite a high dose in a short period of time. And what we did see was that the partial breast had worse cosmetic outcomes using this schedule in the RAPID trial. And then in the B39 trial, a little bit higher rate of grade 3 toxicity, but maybe a little bit less of grade 2. So some mixed results, but again, poses some concern about the doses that were selected for this study. So again, we really like, I think, the Florence schedule if we're going to do partial breast irradiation. So historically, partial breast irradiation had been felt to be contraindicated for lobular carcinomas because of the concern for multifocal or multicentricity. And so really, we've had very little data on this subject. One of the first papers, again, came from Chirag Shah in 2011 when he was at Beaumont and found in small series, again, 16 patients with lobular carcinomas, but no statistical difference in terms of local recurrence, distant metastases rates compared to ductal carcinomas receiving APBI. And then a more recent publication from Moffitt in Florida did suggest a higher rate of local recurrence after partial breast radiation for lobular carcinomas. The rate was about 14% compared to ductal carcinomas, who had a rate of 2.5%. Going back to my own days and early work when I was a resident here, one of the research publications that we had produced looking at our patients, back then we were essentially doing preoperative MRI in essentially all patients coming through at the time. So we had a really good cohort of non-selected patients. And so when the B39 partial breast trial was open here, we wondered whether or not preoperative MRI would have been useful to help select patients for this or not. And so we kind of went through a series of patients over time at that time and found that mammographically occult ipsilateral breast cancer, or DCIS, was found in about 18% of patients with the presentation of lobular carcinoma versus a 3% rate of mammographically occult disease in those with ductal cancers. And so really, I think that was one of our early takeaways, was that if you're going to consider doing partial breast radiation in somebody with a lobular carcinoma, that an MRI can really be useful to help make those decisions. And so a number of organizations have put together partial breast irradiation guidelines. The ABS, which is the American Brachytherapy Society, ASTRO, and then Jacques Estro, which is the European version of ASTRO, both of whom put lobular carcinoma histology into sort of an intermediate category or a cautionary group. So, you know, it can be used, partial breast radiation can be used for patients with lobular carcinoma, but use it with discretion. And as you can see here, a number of other factors that kind of go into the decision-making process. So it is very much not a one-size-fits-all for these patients in terms of decision-making. One note on intraoperative radiation therapy, which we have historically used quite a bit in the past and less so in recent years. This was attractive because it was a convenient option. It can be given during surgery, but unfortunately still a number of patients, up to 15 to 20%, may require whole breast radiation afterwards due to pathologic findings. And I think it's important to note that IORT is not the same as the PBI that we've been talking about. There's a very rapid dose fall off from the cavity, and so there can be concern about microscopic tumor coverage beyond a few millimeters outside of the cavity. And what we've learned over the years is that the in-breast tumor recurrence rates after IORT can be higher than those with whole breast radiation, but we have no head-to-head trials of IORT versus traditional partial breast radiation techniques. In fact, we have no trials of IORT versus just endocrine therapy alone, so we don't even have really great data about just the straight efficacy of IORT in that setting. There's been one paper that I was able to find on IORT showing that there was a higher rate of in breast recurrence after treatment of lobular carcinomas, 22% versus 14% in those who had ductal carcinomas, despite the lobular cancers having more favorable features. So I would just be generally very cautious about using IORT for patients with lobular carcinoma. And then very lastly, just to touch on the setting of post-mastectomy radiation therapy and elective nodal radiation. So generally, indications for PMRT are, I think of stage 3 breast cancer. So in my mind, still thinks of AJCC7 because it's much easier to think than AJCC8. And so somebody with either T4 disease or N2 disease or T3N1 is generally an indication for PMRT. And then the stage 2s are controversial and can be done on a case-by-case basis. And then also positive surgical margins. Unfortunately, we're not as advanced as our medical oncology colleagues in terms of using genomic profiling and other molecular markers to helping make decisions about this. And so hopefully that's an area we'll continue to improve and evolve in. But again, the early data in patients with node-positive disease, we see a marked reduction in terms of local recurrence rates with the addition of radiation for patients with node-positive disease, and that translated to an improvement in mortality rates. With regard to lobular carcinomas, unfortunately, there are really no data to suggest that decisions and indications for PMRT should be any different for lobular cancers than for ductal. And really the only meaningful data in this space that I could find was a SEER analysis, and among patients who did have one of those aforementioned indications for PMRT, it did result in an improvement in cause-specific survival compared to not receiving PMRT, both for lobular carcinomas as well as for ductal carcinomas. So nothing to suggest that we would treat these patients any differently. So to conclude, if we're using whole breast radiation or post-mastectomy radiation, really we don't treat lobular cancers any differently than other subtypes. Unfortunately, the data are limited. But by and large, the outcomes seem to be very similar to those with ductal cancers of the same stage and taking all other things into consideration. If considering partial breast radiation, just remember that lobular carcinomas are considered cautionary per standard guidelines. I do think an MRI would be helpful to rule out other ipsilateral multicentric disease, and I'd be very, again, cautious about using IORT for lobular cancers outside of a trial. And again, thank you for being here today. Nice to see all of your faces. Appreciate your time.